Do you have a pointer? Well, good evening, everyone. Can we have the slides on the screen? If there's a problem, I can play it through my pen drive. Right. So moving on, my name is Akshat Malik. I'll be talking to you about genetics and medullary CA thyroid. There was a lot of no-no from D'Cruza's side regarding molecular testing and all, but in medullary CA it is the heart and soul of medullary CA. I understand it's a bit dry topic, but then I've tried to make it more from a clinical perspective so that you guys can appreciate it more, talking about besides what we generally talk about. There's the brief outline on how I'll be covering this. Now, you can understand any mutation can be either a germline mutation where you can understand the entire organism is having these mutations, or it can be a somatic mutation where only a particular part, say the thyroid is affected, that is having the mutations in it. Now, majority of medullary CA thyroids, they are sporadic, 25% may be hereditary. Now, sporadic ones, they occur later in life, they may be unilateral, they may be less aggressive. Hereditary can be bilateral, they may be more aggressive, they may be associated with Benz syndrome. Now, generally this happens because of red proto-oncogene that is there on 10q1112, and this is responsible for normal, it is associated with the tyrosine kinase. Now, there's an extracellular component to the tyrosine kinase, there's a membranous component, and there's a intracellular component. Now, depending on where the mutation is happening and what codon it is impacting, accordingly we can have these various syndromes and accordingly different types of medullary CA thyroid. So, extracellular one may be meant to a familial medullary CA thyroid, intracellular may be meant to be a FMTC. Now, for extracellular one, 85% times it's because of mutation in codon 634. It will be associated with MEN2A, as you can see out here. Intracellular, 95% of cases may be meant to be. They are heritable in about 95% of cases, and overall it's just 6%. Meant to be is not that common. Ret, of course, is associated with more lymph node mets, more distant metastasis, so it's more aggressive tumor. This is very basic, that MEN2A, what all features are there, and MEN2B, what features are there. It may be associated with CLA and Hirschsprung disease, just brushing through that. Now, what you need to understand out here is when we are talking about heritable medullary CA thyroid. So, in MEN2A, you will have medullary CA thyroid, pheochromocytoma, hyperparathyroidism. MEN2B, again, you are aware of the MTC and pheochromocytoma being present. In familial medullary CA thyroid, you need to have at least 4 family members to be impacted by medullary CA thyroid. If it is less than that, then it is not counted as familial medullary CA thyroid. This just talks about which is the highest risk level. So 918 out here is at the highest risk, and even there are 50% chances of having FEO along with it. Triple plus means 50% chances. So FEO may be present in these cases. Along with that, next high risk would be 883 and 634 mutation. There are certain cases where RET fusion may also happen. Now, this is more commonly seen in other cancers like lung cancer, sometimes in papillary CA thyroid as well. But even medullary CA thyroid may have these RET fusions. Why it is important, I'll come to it shortly. RAS mutations may also be seen at about 30% of medullary CA thyroid. Their H, K, and N are the sequence in which they may happen. Along with that, there are several other mutations, mTOR mutations, CDKN2C, HGF MET. Why we need to be aware of all these is because gradually we are moving on to a stage where we are having treatment for some of these. So that is why it's important to at least know of these. Now, epigenetic modification, this is, here genetic changes are happening because of external sources, not because of genetic mutation per se in the gene, but because of the external sources. So there can be DNA methylation or histone modification, and this can also lead to cancer formation. Now, if there's a red proton gene positive, then we need to assess whether FEO is present or not, and whether it's unilateral, bilateral, and of course, FEO needs to be addressed before we go on with the CA thyroid. After that, we need to see whether there's coexisting hyperparathyroidism. If it's there, then we need to address it along with total thyroidectomy. Now, here is the important concept of risk reduction surgery. So what happens? This C-cell hyperplasia, RET mutation causes C-cell hyperplasia, which can result in microcarcinoma, and this can then result in advanced CA thyroid, medullary CA thyroid. So that's why we need to address these, catch these cases and address them in a timely manner. Now, MEN2B, which has got the highest risk. So here, if we are diagnosing it in child, so the first column is all childhood. If you are diagnosing it timely, then total thyroidectomy needs to be considered in first year. After that, you can do calcitonin and CE every 6 months, and FEO screening starts at 11 years. There is no point in doing it before that. Along with that, MEN2A, there are high risk mutation and moderate risk mutations. So total thyroidectomy before 5 years of age, and if calcitonin level becomes elevated, in moderate risk, and FEO from 16 years of age. In adult patients, if you are diagnosing it later on, so then as you can see out here, you will look at the calcitonin values and accordingly address it. There is no point of doing surgery electively out there. Now, talking about genetic testing, which test to be done? Now, and what sample is required? So if it's a proven, you have a family history of MTC, MEN syndrome, Hirschsprung disease, then you can only test for RET specifically. You don't need to do a generalized NGS. If that is not so, then you can do a generalized NGS where all these mutations will be tested for. What samples? If you're looking at germline mutation, we look at blood, saliva. If it's a somatic mutation, then we take tissue sample. Even for research purposes, we can do a whole genome sequencing. For that, again, we need tissue sample. Now, based on what mutations we are getting, accordingly, we can judge, grade them, whether it's benign, there's uncertain significance, or it is pathogenic. Pathogenic, of course, you need to intervene and do something about it. Now, in variants of uncertain significance, it means that they are not normal, but we are not sure what to do with them. So it depends on what symptoms the patient is having, and we need to follow them up. In fact, what they recommend is that, patients need to go back to the genetic counselor in, say, a year or 2 years time, and then find out whether any new information is available regarding the mutations which they have. Now, what to do for these patients regarding their family? How do you counsel them? So first of all, a cascade testing is required for all first degree relatives. You need to have discussion about reproductive options, whether they want to adopt, undergo gamete donation, or not have children at all. You can even have pre-op genetic diagnosis through pre-implantation, non-invasive diagnosis. Now, if say patient is having medullary CA thyroid and red proto-oncogene is there, then you need to test parents of the individual. They have got about 95% chances in MEN2A and 50% in MEN2B that the parents may also be involved. Children again have a 50% chance, and so do the siblings. Now, here comes another implication of why we need to test for these. So you would have heard of multi-kinase inhibitors, cabozantinib, vantinib, and selpercatinib, which is a RET-specific drug which is available. I'll not delve into this in merit of time. I'll just take 2 more minutes. So vantinib and cabozantinib did had some benefit in medullary CA thyroid, and selpercatinib was a RET-specific drug. So it showed that it has a, I'll just finish it. Just give me a minute. So selpercatinib had a very good response in RET positive patients. I'll just showcase it out here. So this is the survival difference. As you can see that the median survival was not reached out here, PFS, and for other, where placebo was given, it was 16.8 months. And these are all RET mutated patients and including 918 mutation patients. So they had good survival with selpercatinib. So that is what we need to consider if we are having these mutations. And here I've sort of combined charts from different studies, and here you can see that selpercetinib in RAS mutated patients, RET mutated patients are having a better survival. So surgery definitely remains curative for these patients. If there is some systemic progression or there is metastatic or unresectable disease, then we need to consider these drugs, not otherwise. So if there's a RET mutation, you can consider selpercetinib. If there's a RET wild type mutation or RAS, then you go ahead with cabozantinib or vandetanib. Again, if there's a diagnosis of RET, then you do genetic counseling, you discuss with the patient's family, you assess for hyperparathyroidism, pheochromocytoma, you perform surgery, but if there's a relapse, then you consider them for RET inhibitors, which we just discussed about. So RET mutation is mandatory for all medullary CA thyroid, germline or somatic. RET fusions, though rare, but they are also actionable. RET mutation is relevant for prognosis and also for treatment in recurrent metastatic setting, where selpercetinib and pralsetinib do come into role. And integration of genomic testing is very essential. You should have a genetic counselor on board, or at least you can refer to them where they can have counseling with the patient as well as their relatives, and then they can take things forward. So thanks a lot for your patience.